Assalamu alaikum. I'm a consultant in a breast surgical clinic in Hanover. Also, I am an assistant lecturer in the Faculty of Medicine, University of Alexandria. And today we are talking about an interesting topic about surgical treatment and breast reconstruction surgery in patients with breast cancer. We will talk about the standard operations and also the reconstructive procedures. Management of cancer breast goes through a multidisciplinary approach, including surgery, radiotherapy, hormone therapy, chemotherapy, and targeted therapy. And our topic today is about the surgical treatment. Standard operations in treating patients with cancer breast include two operations. First operation is mastectomy, and it means removal of the breast glands. And the second option is breast conservative surgery, means including removal of the tumor with safety margin, but the rest of the breast glands stay. The modified radical mastectomy is the most commonly performed mastectomy, and it is indicated when we find a large tumor size, more than 5 centimeters. Otherwise, we will go through the breast conservative surgery. Also, another indication for removal of the whole breast when we find the multicentric tumor. It means that it is not only one tumor, but we find several tumors through the mammary gland. And it means that the breast conservative surgery or removal only the tumor is not sufficient to get the safety margin. Then we remove the whole breast. Here we see the position of the patient and the choice of skin incision. There are different schools how to decide to take the incision, and we will talk about the most commonly called steward incision. It means an elliptical incision for medial aspect of the second and third intercostal space, as we see, enclosing the nipple, areola, and tumor, and extended laterally into the axilla along the anterior axillary fold. This is the position of the patient, means that the arm is extended laterally to discover the whole area from medial side to the lateral side, including, of course, the nipple areola and the tumor, which you will remove it. And the elliptical incision, when it closed, it means that the end result like a C-shaped incision. S-shaped incision. Here, for example, we see the elliptical incision. Here is the nipple, the areola, here the tumor, and we remove it through exposing the area medially, laterally, and is the most commonly steward incision. Another incisions, but they are not used now because of the cosmetic result, like gray incision. And gray incision, one of its advantages that we make an extended incision till reaching the opposite side. And of course, it is not comfortable to the woman. We take the operation and also scar formation and pain after surgery. Another is green enough incision, and they are double incision, and also because of the wide scar, it is not used now. Another incision is cohort incision. Also, it make a severe post-operative pain and problem with movement of the arm through the extended scar. As we said, the most commonly used now is elliptical incision, steward incision is called. Development of flaps, we raise the skin flap to the level of the clavicle superiorly, the midline medially, and the anterior rectus sheath inferiorly, and the anterior border of the latissimus dorsi muscle laterally. Superiorly till the level of the clavicle, inferiorly anterior rectus sheath, medially till the midline, laterally till the anterior border of the latissimus dorsi muscle. This means we ensure the complete removement of the breast glands. When we remove the breast glands, it should be removed medially to laterally along the muscle fibers of the pectoralis major muscle. Here in the clavicle, anterior rectus sheath, under this hand, the latissimus dorsi, here the midline, and it is removed medially to laterally. The breast, including the breast glands, nipple, and areola. If we need to dissect under the pectoralis major muscle, for example, for removing the lymph nodes, we can underside the pectoralis major muscle by removing fatty areolar node-bearing tissue, and we expose the pectoralis minor muscle. We should, of course, identify and preserve the medial and lateral pectoral nerves to avoid post-operative pain, post-operative sensibility distortions. By axillary dissection, if we need, beside the mastectomy, to move or to remove also the axillary lymph nodes, we should incise the fascia under the pectoralis minor muscle, and we should identify also the axillary vein. Here is the pectoralis major, above is the pectoralis minor. We move it up through, and we find underneath the axillary vein, and this is the fascia that should be completely removed, and this is the level that we should not exceed. Otherwise, we will go through a higher level of axillary dissection that is not used now. There are three levels: level 1, level 2, and level 3. Level 1 and 2, it means removal all the axillary lymph nodes underneath the axillary vein, and if we go through the axillary vein in a higher level, it means axillary level 3, and it is not used now for the high morbidity rate and the complications that meet after the operation. We should not, of course, identify also two important nerves. We find the axillary vein. Underneath the axillary vein, go through two nerves. One go through laterally till underneath the latissimus dorsi, called thoracodorsal nerve, and one go medially, and it is the long thoracic nerve. And there are three structures, as I said, should be identified: the axillary vein, transverse course, thoracodorsal nerve, and thoracolongus or long thoracic nerve. This is more exploration, the axillary vein, thoracolorsalis bundle, artery vein, and nerve, and long thoracic nerve. Skin closure, and we, as a standard procedure, we underneath the skin, we go through two drains. One go laterally, adjacent to the latissimus dorsi muscle, and another in front of the pectoralis major muscle. That's to ensure that the blood and secretion of the operation go throughout these two drains. Patio operations is not used now. As I said, we remove the tumor. We clear also the level 1, 2. Okay, this is the standard operation of the axillary dissection. But Patio's operation go through a higher level and go through over the axillary vein and go through level 3. Plus removal of the pectoralis minor. A radical operation that is not used now for its side effects. Also, Scanlon's operation is not used now. Pectoralis minor should be incised, and level 3 also. Radical mastectomy of halsted, we remove. It is also a radical operation. We go through the thorax wall and we remove the complete breast glands, nipple areola. Also, we go through the pectoralis muscle and we remove it completely, major and minor, plus level 1, 2, 3 axillary lymph nodes. Only what remains with this operation, this is not used also more than 20 years ago, only tissues are retained, no axillary vein and nerve of the serratus anterior, Bell's nerve, and cephalic vein. But every structure in the area of the thorax wall is removed from superior level, pectoralis major, minor, to the axillary vein, and also the muscles. Complications of the operation, lymphedema, and of course, can a further complication from of lymphangiosarcoma. And because of high morbidity, it is not done now. Extended radical mastectomy, the same. It is the same of Patty's operation plus removal of the internal mammary nodes. Simple mastectomy, it is another form of a mastectomy, but it means only removal of the breast, areola nipple, pectoralis fascia, but we don't go through the axilla to remove the lymph nodes. And it is only for the patients with Fowlit's tumor or carcinoma in situ. Complications of the mastectomy, injury or thrombosis of axillary vein, seroma, and this is why we go through two drains, shoulder dysfunction through the scar, pain and numbness, and necrosis infection. Here we see like winged scapula situation, and it occurs through the injury to the intercostobrachial nerve or the medial and lateral pectoral nerve. Can also for pectoral muscle atrophy. Lymphangiosarcoma, Stewart-Treves syndrome, developed in the upper limb of the patients who developed over years lymphedema after mastectomy with axillary clearance. Patients come with multiple subcutaneous nodules 3-5 years after the development of lymphedema, and unfortunately, we should remove the complete arm amputation with a poor prognosis. Now, we have talked about the first operation, mastectomy, one of the standard operations with several procedures, the modified radical mastectomy, and the other extended radical mastectomy, and now the other option for the standard operation is only to remove the tumor as a breast conservative surgery. It is most commonly used, ideally done as wide local excision with sentinel lymph node biopsy or axillary lymph node dissection, but it should be completed with radiotherapy to the breast and chest wall. The incision should be a curved line, not radial line, to consider the scar formation and to avoid post-operative pains. Separate incision for the axillary dissection, and it is limited for the woman with small tumors, smaller than 2 or 3 centimeters. But as we say, radiotherapy should or must be completed. Here, we go through curvilinear incisions and a separate axillary incision. Not lung incision, also here not a lung incision to avoid pain and to allow free movement of the shoulder. Indications, as we say, tumor is smaller than 4 centimeters, negative axillary nodes clinically, mammographically detected lesion, adequate size breast to allow proper radiotherapy to the breast, and of course, the relation between the tumor size and the breast size should be adequate. Not, for example, I speak about 3 centimeter or 4 centimeter tumor, but the woman has small breast. It will be not a condition that can be can we do the breast conservative surgery in an optimal way. Contraindications: tumor larger than 4 centimeters, pregnant woman, of course, multicentricity, multifocality, it means several tumors in the breast, central tumor, that means tumor breast ratio proportion is high, tumor beneath the nipple, extensive cancer in situ, intraductal carcinoma, and of course, when the skin is involved, it is contraindicated. Inflammatory breast cancer needs only mastectomy. When the skin is involved through the cancer, we should remove the whole breast. Skin sparing mastectomy, it is a condition that we can remove the whole breast glands through a small incision, like a keyhole. This can be used in central tumor or tumor that is multicentric. That means it is involved in several areas of the breast, and this is operation I have already for 2 months ago. The patient, as we see, has a scar because we have operated through a detected tumor, and after the operation, the pathology report said that it is an extensive ductal carcinoma in situ, and we have done an MRT examination that is not at standard in the diagnosis, and have confirmed that there may be multicentricity, and we should do another incision here, and we have removed the whole breast glands, as we see, and we can then like a silicone implantat through this incision for the symmetry with the other side. The goals of reconstructive surgery after a mastectomy is symmetry done in young patients with early stage of disease. Not only treatment, but also we should consider the cosmetic result. Factors deciding the reconstruction amount of the skin, as we see here, for example, we have removed the whole breast glands, but not the skin, and we have a good amount of the haut that we can make a reconstruction, for example, through a silicone implantat or a flap. Amount of the skin, as we say, retained stage of carcinoma, radiotherapy, yes or no. Immediate reconstruction, it means that we do it direct after the operation of tumor removal or breast removal, or parallel after removal of the tumor at the same session, at the same operation. In early stages and in some selected advanced cases, not advised in local advanced disease, because of course it needs radiotherapy, and it is recommended to wait after the treatment, and then we for radiotherapy, and then we can after that we can make the reconstruction operation. Delayed reconstruction, this means 3 to 9 months after surgery. The most important indication that radiation is needed or expected in post-operative period, or the patient is unfit for prolonged surgical procedure. That means we make like a distance between the first operation and the second operation. The advantage that avoids fibrosis and fat necrosis if we need radiotherapy after the operation, and allows for post-operative radiation without side effects. Methods of reconstruction. We can bring artificial materials like implants, breast implants, silicone, or expanders. We can fill it with saline, or from the tissue, or from our body, like the muscle reconstruction, latissimus dorsi flap, transversus abdominis flap, superior gluteal flap. Breast implanted, it is technically simple, good result, achieve symmetry. We control the size of the silicone that we need, can put it under the muscle. It is better for more stability. If the muscle is weak or removed, then we light direct under the skin. Here, for example, here is an implant directly under the skin, and here is under the muscle, and we can see that is more stability if we light under the muscle, if it is placed under the muscle. Complication of implants, pain, exposure of implant, rupture, displacement that moves through the axilla, infection like a foreign body, and contraction, capsular contractions. Flap reconstruction, that means from the tissue of the patient, latissimus dorsi flap or trunk flap, it is several opinions. Latissimus dorsi flap, we remove the latissimus dorsi from the back and we move it forwardly, and it covers the defect after the operation and removal of the breast. It is favorable, easy, and with few complications, but we may need like an implant because the latissimus dorsi flap is small, and for the symmetry with the other side, we may need a prosthesis, an implant. With trunk flap, it's more complicated with more side effects, but it gives good bulk, no need for implant. If the patient wants only tissue of hair body, we go through the trunk flap. If she is more flexible, then we go through latissimus dorsi flap. Here, for example, we see the back. We move the latissimus dorsi with the skin paddle, and we move it from the back through a tunnel under the skin, and then we go forward to cover the defect. Trunk flap, also we remove the rectus abdominalis muscle, and under the skin we remove it through a tunnel, and we go through the defected area. Of course, we should consider the blood supply should be preserved through the thoracodorsal vessels for the latissimus dorsi and the deep superior epigastric vessels for the trunk flap. Here is also another picture. Here the skin bundle. Here the thoracoldorsalis nerve should be preserved, moved under the skin, go forward and defect the area. Here can like pigmentation tattoo to give the shape of the opposite side of the nipple and the areola. And if it is small, we can go through also an implant to give the symmetry with the other side. Here, for example, is a flap with a latissimus dorsi. It is also from my operations. Here we see the patient refused a silicone, and we can see here the asymmetry, and this side can we, after through a third session, this side we can we can make lifting, and we can go to the symmetry on the other side. I think we have talked now about the reconstruction. As I said, silicone and flaps. Silicone is easy, and with flap it is better because we use the tissues of our body. Every operation has its side effects, but we should also consider our cosmetic forgiveness and the psychological impact of cancer breast for all the patients. Thank you, and I hope that I go through the main topics and items for treatment or for surgical treatment of patients with cancer breast.